my thanks to the organising committee for the opportunity to present our data on elderly patients in England, not just fat patients in England, but elderly patients. And my sincere thanks for bringing us up the order, because whilst we're not barely in Europe anymore, there still is a very good railway that connects London to its suburbs here in France. Unfortunately, Kavitha Madhuri, my research fellow, is enjoying her stay in France so much that she's completely lost her voice. So at the last minute, I'm afraid you've got to put up with me, Simon Butler-Manuel, presenting some data from our unit in Guildford. I think the elderly are often quite neglected in many ways. There's very little data with regard to cancer management, and they're often excluded from studies. Of course, the elderly are those most likely to develop cancer, and it's strangely rather poorly defined. I look forward to a new retiring age in England of 67, and I think other countries in Europe are catching us up in the way that things are going. So I'll either die in service or retire at 67, whichever comes first. We've specifically used our database to look at those over the age of 75, because in our experience, they're the group where management seems to often change or be curtailed. But it's a very disparate group of people. The needs of older people are not one and the same. And in the south of England, where I live and work, in fact, there's often quite a healthy subgroup of people who are living longer and longer, and it's not unusual to see people presenting in clinic in their 80s and even in their 90s. There are, of course, legacies of the old days. Not many people in England smoke now, but alcohol consumption is on the up still, and we're getting fatter and fatter. And we've presented our experience on obesity surgery and the prevalence of endometrial cancer in our population previously here. This theme of the elderly and cancer was picked up a couple of years ago by NHS England, and a very focused report on this was published with data on all of the main common cancers in men and women. And they stated that people aged 75 can expect to live for another decade. Evidently, the risk of cancer increases very considerably as one gets older. In fact, 2/3 of cancer cases occur in those beyond retiring age. And that equates to about 2 million people with cancer over the age of 65. Conversely, whilst you're more likely to get it, the outcomes are poorer, and it's less well defined as to what the correct treatment algorithms are and what treatment they actually receive. And the older you get, obviously, the more likely you are to die and succumb to other things as well as the cancer itself. So it's a bit of a hodgepodge of data, really. But I apologise for this busy slide, but this is from NHS England, and if you, in amongst there, you'll see that, I'm not sure I can do this pointer. One of the, I can't do it, but what you'll see is that the incidence of uterine cancer is the pink for appropriately uterine cancer. About 25% of those with endometrial cancer will not receive surgery over the age of 75. And similarly, poor figures for ovarian cancer. Bearing in mind that's the standard procedure, never mind assessing the para-aortic nodes, it's doing the hysterectomy that's the most important thing. So there are a number of issues going on with delayed diagnosis, often multiple comorbidities, access to treatment, and as I said, often some of these patients are much fitter than you might imagine. And of course, none of the clinical trials really thus far have really focused on this group. Often people over the age of 65 are excluded. We're a medium-sized cancer centre in the south of England. Our network, we've drained a population of only about 1.5 million, there or thereabouts. We're quite interested in minimal access surgery. It's something that I've developed there, and we've been doing robotics since the end of 2009. We're an epicentre for training, and have the greatest experience in Britain. So that's just a sort of background as to who we are. So you'll see in Britain, these again are taken from the NHS data, that the vast majority of the elderly are overweight, 3/4 of men, and for us 70% of women are overweight. Women, although surprisingly not being so fat overall, are less active. And a number of the patients that I see have comorbidities, particularly involving cardiac and respiratory diseases. And all of those with atrial fibrillation are on warfarin or other anti-thrombotic agents. In the last year or two, we've been working on how best to assess people. They're sent in from other centres to us. There's a time frame that we have to work within. Patients have to be treated within a month, and getting all the appropriate investigations and information about investigations that they've already had can be quite a handful. So we've developed quite a tight system, simple form, to try and glean all of the information that's out there in patients' hospital records and get it together, bundled up, so that we can assess people and, if need be, get them into a high-risk anaesthetic clinic. They're not all seen by a consultant anaesthetist, but their notes are reviewed, their investigations are reviewed, and those where it's felt that they are particularly high risk, they are seen individually and might be put through cardiac testing on a treadmill. Perioperatively, it's the inability to tolerate prolonged GA, and there's quite a bit of evidence out there in the anaesthetic literature as to the risk of perioperative mortality, myocardial infarction. So patients do need to be assessed properly, and you need to have a plan in your mind as to how proactive you're going to be with the surgery. The biggest issue that we face in getting patients home are actually social care problems, not medical care problems. Surprisingly, that's a particular problem in England, where we don't have the lovely close-knit family unit situation, with increasing social problems from marital breakdown and familial breakdown. So, as I said, all data is extracted from our prospective database. We include all of our cases, work of my colleague, Mr. Taylor. And up to the time that we analysed this data, we'd done 855 cases of, within the oncology subgroup. We've done about 200 benign cases on top of that. So it's about 150, 160 cases a year, the majority of which are under the age of 74, but 22% are over the age of 75. And we've stratified those into these three groups: 75 to 80, 81 to 85, and greater than 86. The majority being endometrial cancers or corpus cancers. We haven't subdivided those histologically, so that will include sarcomas, triple MTs, and so on, and some with metastatic disease. The younger patients are actually fatter. So we're seeing that as patients get older, they're actually slightly slimmer, but they have other comorbidities, as I said, particularly cardiac and respiratory, with a significant cohort there with atrial fibrillation, and still a significant number who smoke. But hypertensive disease, type 2 diabetes, AF are the commonest things, with a significant number of patients having ASA 3. The surgery tends to be pretty simple. As I say, the commonest indication is low-grade endometrial cancer, so we're really interested in doing a hysterectomy, BSO, plus or minus node sampling. We've done selected cases of elderly patients with ovarian or primary peritoneal cancer, particularly to get the mass out. So very much tailoring the surgery to the patient. But we're pleased with the results overall, and there have actually been very few adverse events. 2 of those admissions to intensive care are planned, so only one unplanned ITU admission in nearly 200 cases in this very elderly population. 88% went home the next day. Not 4 days later, the next day. And with a 0 30-day mortality. Curiously, we've had a little group of inappropriate ADH secretion with hyponatremia. I've actually been a bit cross with the juniors for checking the sodium level on these patients, but with hyponatremia in asymptomatic old folk, preventing them from going home. And I wonder whether this may be iatrogenic. In fact, I'm sure it's iatrogenic. I wonder whether it may be the omeprazole that we're prescribing them rather than simple ranitidine, but I digress. As I say, predominantly endometrial cancer, predominantly early stage, but a significant number of palliative procedures. Old ladies with high-grade endometrial cancers who are bleeding, the treatment of choice is a hysterectomy. So why not do it with the robot? Why not send them home the next day? I think there is more focus coming in this group of needy patients. This is a huge study from the States, retrospective study, but really using public health data of thousands of patients. And clearly robotic surgery for the elderly is being used wholesale in the States. And another different approach is a smaller matched prospective cohort study suggesting that really the other histological factors have much more bearing on these endometrial cancer patients rather than their age. In terms of our service provision and what we can do, I think we can probably work better towards planning the discharge care of these elderly patients. And we have a team of old person assessment and liaison, because as I say, social problems are actually the main factor delaying discharge. And I feel very strongly that age alone should not be a barrier to treatment. Thank you very much to the team and to Kavitha.
Thank you very much.